This program is brought to you by Emory University.
So it's a privilege for me to introduce today's speaker, Ambar Kulshreshtha, who I hope I got that right, Ambar, apologize, who is an associate professor in the Family and Preventive Medicine Department at Emory, and I think a lot of us on this call know him. He trained in medicine in New Delhi and then came over to the US and did his MPH at Harvard and then did his PhD in the School of Public Health in Epidemiology. And as he was alluding to earlier, he also worked with us on the MIPS and MIM studies, and he blames us for the rest of his career based on that, I think, which has been illustrious. He then came on faculty and has risen to associate professorship very quickly, has very good funding, and his main interests are the link between heart disease and cognition. And that's what he's going to talk to us about today. So, Ambar, thank you very much.
Thank you, Dr. Kayumi. Really appreciate the invite and the opportunity to present to this group. All right, I'll begin with an outline of my talk. So I'm going to be talking about what is cardiovascular health and how it may relate to cognition. And you cannot talk about both these topics without talking about the disparities that exist. And in some sense, I've been in the Alzheimer's community for a few years now, and I feel like there's a lot we can learn from the cardiovascular community, which has seen a similar rise in cardiovascular diseases and then almost like a plateauing. So is it the drugs and procedures are simply not enough to really reduce these big epidemics? And then we're going to talk about the vascular role in Alzheimer's disease, and I will inform you briefly about the exciting developments that are taking place in the Alzheimer's world. So I want to step back and think about like how there is always this search for something like a holy grail that could just like one drug that could have multiple or like a pleiotropic effects, and it could reverse aging, solve multiple problems. And of course, statins, as we, several years ago when I attended AHA, statins was touted like a drug that could reduce inflammation, not only cardioprotective, but may prevent cancers, could reduce dementia, as we are currently in a trial called the Preventable to investigate if it actually helps in preventing cognitive decline. And every now and then, metformin comes back again, being again like a wonder drug, which could also have anti-inflammatory properties. And of course, you've all seen how SGLT2, GLP-1s are being touted as the holy grail for a lot of medical conditions, from heart failure to renal disease and everything else. And of course, there is also Arshad's favorite stem cells that also could potentially hold in terms of like multiple conditions that it can actually be helpful for. So where are we going with this? Wanted to talk about dementia, which is one of the most debilitating conditions. In fact, it's the third major cause of disability. So when we try to think about these holy grails, it definitely needs to tackle beyond heart disease and cancers, dementia. And just before I go more into dementia, just to keep in mind that dementia is a very broad term. It's almost like a syndrome, with Alzheimer's being the biggest part of it. But there are other ones, and there are some of them that are reversible that we as primary care docs try to rule out. But then there's the Alzheimer's. So, and you're all familiar with this, that dementia is such a growing problem in not just the United States and developed world, but all across the world. The number of projected cases are going to go up to 14 million. You can see how it's responsible for 7 million adults currently have dementia, and sixth leading cause of death. And you can imagine with the cost of unpaid care is extremely high. And, this makes it one of the most costly diseases for the society and healthcare systems. And I was intrigued from an epidemiologist perspective because it's one of the few causes of death that really does not have a definitive cure even now. But we like to talk about, in US, a lot of top 10 causes of things. And, you can see that from CDC data, it's always heart disease, cancers, and Alzheimer's is number 6. But this work done by Bill Fagey and then updated by another epidemiologist from Rollins, who was really behind a lot of the the COVID data collection and monitoring, was Ali Mogdad. And he published in JAMA what are the real causes of death beyond what we see reported in death certificates. So the actual causes of death, not surprisingly, almost like half of them can be attributed to poor lifestyle. And that became an important one, which AHA was trying to look at when it was seeing the overall trend data for cardiovascular diseases, that it's just starting to plateau, and no matter new drugs or devices and procedures are going on, but it's still not coming down. So they looked at 3 concepts, and I wanted to emphasize how can we really achieve this further decline in these epidemics like cardiovascular disease and dementia. And in cardiovascular, we have really aced this in trying to identify patients with high risk and trying to reclassify patients in intermediate risk, and then low risk goes back to primary care. But so the high risk strategy is definitely an important tool, but it's actually the population-based strategy that really give you a lot of dividend in terms of that if you even try to change a small proportion of, let's say, reduction in salt or reduction in blood pressure, you could achieve risk reduction in a major way. The thing with high risk strategy, of course, as I mentioned, the impact on total burden is small. We keep on going after this risk stratification and focusing on high risk. But the population-based strategy, just like you can think of the trans fats that was done in New York City, where the whole population is like you're just eliminating trans fats, and that actually leads to a substantial reduction. But the motivation to do it is pretty low, and it's, as you can imagine, how hard changing policies and trying to fight with the big industry is. It's always challenging to do. And this concept was laid down by a very famous London-based epidemiologist called Jeffrey Rose, and AHA took on this thing. The next thing is also to remind ourselves that, the risk factors are operating at all levels in how cardiovascular disease happens, primary to tertiary prevention. And interestingly, when I'm studying Alzheimer's now, it's actually a very similar thing. It's like risk factors are operating, and even though they don't talk much about primary, in the same way, but it's like mild cognitive impairment leading to dementia, it plays out pretty similarly. This is one of the works that, of course, AHA used when it tried to develop the construct of cardiovascular health. It's, the work was done by Lloyd Jones, and the idea was that even with just one risk factor for both men and women, you could pretty much have a major jump in risk for 36% in men and about 27% in women. And then the more uncontrolled risk factors you have, the risk just continues to grow. So we don't know about a holy grail, but AHA definitely came up with this cocktail of Life Essential 7, or initially it was called Simple 7, but they changed and added on sleep. And then the idea was to have a positive construct of like modifiable risk factors. And this was started in 2010. I was doing my PhD at that time, and I felt like, okay, this is interesting. And now from a primary care perspective, I actually like it even more, because a lot of times when you see patients in clinic, it's always a discussion about disease prevention and this and that. While this spins it into a different way by calling it, that you are promoting heart health and now brain health. So I did like it, and in the sense it not only has a public health value, but individuals can go calculate, put in their modifiable risk factors in an app and generate a score, and it'll give you suggestions on how you improve it. So the idea is, again, of AHA and CDC also adopted this for monitoring population health, is to come up with this construct which is positive, measurable, and already has good evidence for CVD disease-free survival. And I think most of us doing research are familiar with the cardiovascular health construct. But at that time, when it was started, they had like these metrics that were laid down, some with strong evidence, others somewhat weak. But you had your 3 physiological factors like blood pressure, serum glucose, cholesterol, all categorized into ideal, intermediate, and poor. Now, we can debate about some of them, but that's how AHA felt it should be done. And then looking at behavioral factors, and in this one, you look at smoking, physical activity, healthy diet score, as all of us could imagine. It's based on the DASH-like eating plan with more consumption of fruits, vegetables, fish, and fiber-rich, and less of sodium and sweetened beverages. And now, more recently, they have added on sleep to this metric, given the importance of sleep in cardiovascular disease prevention. So when the concept was originally placed, we looked at this in a major study called the REGARDS, which is a national cohort study looking at incidence of stroke being so high in the Southeast area. And this is the stroke belt, the yellow states that I've marked over here. And stroke mortality is 20% higher than the rest of the US. And we wanted to understand how does the cardiovascular health play out over here. And just to give you an idea, this REGARDS study is like a Framingham for stroke, actually, with in-home examination, a lot of biomarker collection, and now as we are evolving and trying to add cognition markers in there too. And it also has repeat measures now. So what we showed at that time was that if you put the cardiovascular health into a metric format with 1 to 14 being the score, even a small increase in your cardiovascular health, which is basically an improvement in your cardiovascular health through all the physiological and behavioral factors I mentioned, it can actually lead to a reduction in your stroke. In fact, 8% reduction in stroke, which is great. So I think what we really emphasize over here is that even a small change, just like what I showed you in the Jeffrey Rose thing, if you change it at the population level, you can get a significant reduction in your cardiovascular conditions, and we'll soon see other as well. So, of course, if you look at it, the more number of ideal health metrics you have, the lower your risk for stroke. And again, this was a major study that actually helped to get this idea off the ground that small changes are really helpful. Now, if you can change them, that's the key question, and we'll get to that later. So, and this finding was replicated in several other cohorts. This is from ERIC data looking at coronary heart disease. And of course, given that all these factors already had evidence behind them, it's not surprising to see they work for heart disease, heart failure, and atrial fibrillation. So there was similar reductions if you have the more optimal cardiovascular health. But it became a nice outcome for people to look at in their longitudinal databases. And I think more than like 3,000 papers have been published and is being used not only in US, but across other countries to monitor population health. But I thought this was interesting when this Lancet Commission reported about dementia, and it seemed like we have a very similar story playing out over there with 40% of dementia being really modifiable. And if you look at this, there's, early life, midlife, again, you have hypertension, obesity, and later life, you have smoking and depression. So this kind of lays the idea that, if lifestyle can play a significant role while we are still awaiting for good drugs that can be disseminated across the population, there is something we can still do with lifestyle that can prevent dementia, because there is mechanistic pathways to prove this. The problem is, of course, implementation. So 1 in 3 dementia cases can be prevented by lifestyle factors. And again, as I mentioned, with this all operates along the lifespan. And it's almost like a balance, we frequently think about of things that are what leads to cognitive reserve and what leads to the risk. So it's almost like a balance of factors that can actually predict how your brain health trajectory would look like. So having multiple languages that you can speak can be protective. Having more education can be protective. But then people can have, of course, risk factors like depression and all, which can lead to inflammation, oxidative stress, endothelial damage, and interfere with the clearance of tau and beta amyloid in the brain. And the study from Yaffe and Dr. Barnes actually showed that this works. This similar kind of reductions can be expected in dementia too. In fact, you can see that a 10 to 25 reduction, if you do all of these 7 risk factors, can prevent as many as 3 million cases worldwide. And so the idea of heart health to brain health was just laid out like this, that in the REGARD study, we showed, our colleague showed that, again, the same cardiovascular health concept can be used for showing improvements in different cognitive domains, including executive function, recall, and things like that. So this REGARD study showed similar thing. And distilling it down further in this study from in the Northern Manhattan study, we can see that the more number of ideal cardiovascular health factors, the more you have, the better it is for your different cognitive domains. Sorry, this slide is slightly blurry, but you can see it's processing speed, semantic memory, executive functions can all improve the more number of cardiovascular health factors you have. Now, this is data from the Framingham study, which is actually is interesting because this is from the offspring cohort and had data on 2,700 participants who were initially stroke and dementia free. But what it kind of compared cardiovascular as well as like stroke, for example, with vascular dementia. So what was interesting here is that in contrast, the association between ideal cardiovascular health and stroke was similar for both recent and remote variables. What was interesting is that remote cardiovascular health was actually a better predictor for all-cause dementia compared to stroke, for example. And that point is that because stroke and cardiovascular disease are more like acute events, what it lays out that for dementia, that develops over a long period of time. And and that's why the emphasis on midlife factors may be really more important for preventing dementia. And you can see it made a difference in not only just different cognitive measures. These Trail A and Trail B are really like kind of tests that you do for patients to assess different cognitive domains, and also look at brain volumes, which also made a difference depending on when your cardiovascular health was. So I had the opportunity to work with Viola Vaccarino in her twin study, and which I think is one of the most fascinating study designs, is because you can twins and even adoption studies can be used to discriminate between nature versus nurture. And from an epidemiologist perspective, it's one of the great designs to really with a counterfactual, which your twin becomes your counterfactual if they are discordant on one exposure. For example, PTSD, as we see in Viola's studies. And just to remind everyone, the way you distinguish is the monozygotic twins, they share 100% of familial and genetic influences, while DZ twins share 100% familial and 50% genetic influences. And when you examine these associations in both MZ and DZ twins, you can really assess for genetic and familial confounding. We kind of use these analyses to understand how much each factor can play a role. All of us working here, if they're familiar with the twin study, which when I worked on it, we looked at the sample from the Vietnam era twin registry and excluded twins with a history of CVD. And data collection has been ongoing and with repeat measures too now. And what we found over here, that after accounting for the correlated data using mixed models and everything else, that the association between cardiovascular health was shown with several cognitive domains, which I already showed you was not exactly surprising. But what was interesting again here was the association between cardiovascular health and cognitive tests was weakened in the within pair analyses, which really suggests that familial factors such as early environment and education plays a major role in this association. So again, going back to how early life factors and midlife factors can be important. So the cardiovascular health, to summarize, has really become a popular concept in cardiology, but also spread to other fields. And as I mentioned, even in other countries. We were one of the first to actually look at carotid IMT and how that relates to cardiovascular health. And of course, not surprisingly, the better cardiovascular health you have, your carotid IMT tests are improved. And then, but in a range of outcomes, you could see that just even a small improvement in cardiovascular health, you can benefit in 18% reduction in deaths, heart disease, end-stage renal disease, depression, and all that. And I kind of find this really powerful when I'm trying to emphasize the power of lifestyle changes to my patients in primary care who are, not only just interested in preventing heart disease, but also other conditions as well. So with that, we wanted to, the small changes may be powerful, but I think we have bigger problems in our in our disease epidemics. And one of them is really the disparities that we see. So this, as you can imagine, whenever you start plotting in a map of different, whether it's heart disease, strokes, dementia, the Southeast always shines bright, right? It's so this shows you the prevalence of dementia by residents. And in this one, you see the age-adjusted death rates from dementia, which again, Southeast always is showing the stark disparities we have, where deaths from dementia can be pretty significant in Southeast. So I was interested in urban-rural disparities and differences in dementia. And not surprisingly, again, we found that it's the Southeast central areas that show higher dementia deaths. And in the rural counties now seem to be performing worse and in terms of dementia. And that's one of the reasons why there's a lot of emphasis on how whatever programs that we develop in academic centers can be actually extended out in the community and even rural areas. And I'll give an example of that towards the end of my presentation. And we are all familiar, anyone working with Alzheimer's and cardiovascular disease are well familiar with the racial differences that are there. So in the regards cohort, we found that African-American women and African-American men, you can see in yellow and green over here, they continue to have poor ideal factors compared to white women and white men. And again, this is data from the Kaiser Permanente and shows that African-Americans had higher incidence of dementia compared to other groups. But Asians seem to have the lowest, but I feel like when we lump the entire continent of Asia as Asian Americans, you're really missing out a lot because we are kind of trying to understand how, for example, South Asians who have a large predominance of vascular risk factors can still have lower dementia risk. Is that really true, or we are really not seeing the true dementia rates in this subgroup? So, of course, like why is it that African Americans tend to have higher risk and Hispanics have 1.5 times the prevalence of dementia? And part of this can be actually explained by the role of vascular factors. In fact, so this is data from the Rush cohort. These are patients who are deceased, and you can see over here that compared to whites, in African Americans, there is actually a bigger role for infarcts, which is the vascular pathology over here. So the true Alzheimer's seem to be less compared to whites. And so vascular pathology could be playing a big role in why we see these stark differences in African Americans and Hispanics and probably even South Asians. So this ties in the whole concept that yes, heart health can be very similar to brain health if you work together in all these risk factors, but the important role of the vascular health is intriguing over here, because it can play a role in small vessel disease and of course, large artery atherosclerosis, and of course, the vascular risk factors trying to amplify all these factors. When I look at the Alzheimer's world, it's almost like there are multiple groups that are focused on one particular pathway that they feel is the most important for Alzheimer's disease pathology, the tau tangles and plaques. And it's usually whether it's the amyloid cascade hypothesis or the tau hypothesis, but the role of vascular is sometimes put on the sideline. But I feel it definitely plays a big role, as you saw from some of the studies that I just showed. So and of course we have that with the modifiable risk factors, which operate not only in the vascular factors and the environmental factors, they lead to the cerebral vascular damage and cause the neurovascular breakdown, leading to the blood-brain barrier dysfunction, leading to vascular dementia, which does contribute a little bit to Alzheimer's, being and by itself a separate pathology as well. So I was interested in looking at how can we really, how can you pick up vascular pathology beyond just measuring of risk factors? And one of the tests to do that is called a cerebrovascular reactivity, which is basically you see the response of the blood vessels to CO2, and that reflects microvascular function. And it's already well known that it's impaired in hypertension and stroke. And the test is kind of a little complicated, which I feel like won't work in most clinical settings, is you have the patient inhale CO2, and then you measure the vascular function and see how the patient does. And we were curious to understand if there is a relationship between CVR and cognitive performance, and is this relationship different between African Americans and whites? So we used a protocol which was developed by Dr. Hajar, who was here at Emory a few years ago, and the protocol and the patients are put in this sequence of MRI. And what we found is when we looked at data on cerebrovascular reactivity on 219 participants, 46% African American, which was one of the best things that Dr. Hajar's study did, is enroll significant number of minority or underrepresented communities like African Americans. And what we found was that an increasing resting whole brain CVR, which is good because your vessels are more reactive, it actually was associated with higher overall cognition, which is the MoCA test, that is Montreal Cognitive Assessment Test. It's associated with better language and better executive function, which is your ability to do things with your hands. And then we also found that CVR was associated with better performance in all cognitive tests for African Americans, but not for whites. Now, why would that be? Is again, the role of the microvascular dysfunction could be more important in African Americans compared to whites. So I thought that was fascinating to see this. What we really want, the CVR, as I mentioned to you, is a much more challenging test to do. But what if we could really measure vascular function in peripherally? And this is one of the works done recently by Matthew Gold. And this uses reactive hyperemia index, which is measured by a thing called EndoPAT. And this was data again, collected by Dr. Kayumi and Dr. Hajar from the vascular study. And we had 152 participants, 40% Black and about 33% male. What we found was that peripheral microvascular dysfunction was independently associated with mild cognitive impairment and approximately doubling of the odds per unit decrease in reactive hyperemia index, which basically means that if your RHI is poor, your risk increases. But this was a really nice analysis done by Matthew, and it shows again the role of microvascular dysfunction, which seemed to be much higher in Blacks compared to whites, 21.3% compared to 15.9% in whites. But of one of the recently completed studies that we just did, beyond the vascular test, I feel like one of the more promising markers is really arterial stiffness, which is done, as you might all be familiar with, the pulse wave velocity test. And what we found, this is from data in the Emory Healthy Brains study, which had 760 participants. And this is a major study being conducted at Emory, and has almost like 2,000 participants now. And the great thing about it is that it has CSF biomarkers, really detailed imaging, MRI scans are available, and a lot of ways to get down to amyloid and tau pathology pretty clearly. So in this one, we just recently submitted this, which shows that pulse wave velocity, basically meaning that the more arterial stiffness you have, it is associated independently with AD biomarker. And it kind of reminds me of like how there's almost like a saying that when people in the South used to die, that they used to say they used to say that their arteries have become hardened. It just kind of that people already was sensing that arteries hardening is really not a good thing. So I felt like this was a fascinating thing to see that it's also associated with AD biomarkers. And this data that we are working on from the NAC cohort, which is basically all the Alzheimer's disease research centers across the country, there are about 30 of them that pool their data together. And we're starting looking at how cardiovascular risk factors play a role in AD. And what we find over here is that you can see the prevalence odds ratio and then the hazard ratio. So you can see that stroke and TI are not surprisingly associated with AD, but also that in follow-up, you can see that heart failure plays such a role. And there's more and more literature coming out about how heart failure, probably impacting cerebral blood flow, can be an important predictor for developing Alzheimer's and vascular dementia. So I've mentioned to you about how these various cardiovascular health is so important, and I don't know if anyone wants to take a guess, but this is like a portfolio of cardiovascular health in the United States, with green being the ideal. And if you are surprised to see the number of people at ideal health is not really a typo, but there's really very few people who actually have the healthy diet score. In fact, if you look at all people in the US who have really cardiovascular health at an ideal level, it's surprisingly less than 1%. But when I look at this, I was always intrigued that why did they not take stress into account? Like what happens to stress, which plays an important role in cardiovascular diseases. But AHA, in its most recent reiteration, actually showed that stress being hard to measure, it put it in its own cloud around these cardiovascular health factors, that all these stresses are important and may play a role. But just because of the problems with standardization of stress measurement, it did not put it into a separate factor, just like it did with smoking. Now, in my career, I think somehow I've been followed, stress has followed me in a way, because when I was in Boston, I actually had the chance to work with a famous cardiologist called Bernard Lown. And he was at that time 88 years old, and was probably the most active person in any meeting, even at that time. And just to understand his contribution to cardiovascular literature is that he founded the concept of CCU. He, of course, had a syndrome after him, and on his side hobby had satellites, and won the Nobel Peace Prize for the International Physicians for Prevention of Nuclear War. This was around the Cold War era. So even at that time, in his early years, he had really said that stress plays a big role in cardiovascular disease. This is a thing he founded, he published in 1973 about how stress may lead to heart instability. And, I've been trying to understand if just the way stress can impact heart, can it actually impact cognition too? But it's, of course, a really complicated thing when you start understanding stress from an Alzheimer's perspective, because, of course, the moment anyone starts having any cognitive complaint, the first thing they do is they get stressed. So what comes first is always challenging. And then there's this whole complicated path, whether you are stressed and different kinds of stress, because if it weren't for stress, I probably wouldn't be here presenting. So some bit of stress is actually helpful. But the more chronic stress you have, how that impacts your compliance with medication, leads to CV, poor control of CVD risk. And of course, its impact on cortisol levels and everything, and also impacting the structurally in the brain. So I looked at stress, and our friends back in Regards allowed me the opportunity to examine stress in relation to cognition. And this was one of the studies that, again, got a lot of attention, because, again, stress being so common, We showed that perceived stress, you can measure stress a bunch of different ways, but perceived stress is probably one of the most important, because if your cortisol says you are stressed, but you are not stressed, I don't think so you're still stressed. So we showed an independent that perceived stress can lead to poor cognition, and we showed it in a longitudinal format too, which is that if we group people into high levels of stress before, but then change to low levels. In fact, the group with the highest level of or poorest cognition were the ones who were stressed before and continue to be stressed in a high stress category. So that showed that there is really, even though the relationship is definitely bidirectional, but there's stress definitely contributes to poor cognition. Now, how do we apply this to Alzheimer's? And that's what I've been doing during my K23 training, is trying to see how stress and some of these vascular risk factors play a role in cognition. And the field of Alzheimer's has become really interesting, is because we have realized, just the way we realize in cardiovascular, is that disease has already starts happening way before clinical symptoms happen. So even in cognitively normal people, even almost 15 to 20 years before, amyloid accumulation has already started. And then by the time they are being diagnosed with MCI, some neural injuries happen, and clinical symptoms really happen late. Now, so interesting, when I was attending AHA and ACC, it was like every year I used to go to a conference, there's new drugs, new procedures, new interventions coming out. In Alzheimer's, when I started a few years ago, it was like for a good period of time, the conference was pretty much looked very similar. There was like, other than maybe some imaging biomarker development, there was kind of nothing that changed much from one meeting to the next. But just in the last few years, this field has become super exciting. And we have like new drugs like Leqembi, which you might have heard about, is one of the drugs controversial in terms of its real effect on cognition and the huge and some of the side effect profile. But at least we have had a breakthrough after hundreds and hundreds of trials that have failed in Alzheimer's area. But more interestingly, for beyond just the drug itself, it's also the biomarker field that has just gone through a real revolution over there. So not like till now, the only way you could really diagnose whether a patient has an amyloid pathology and as AD signatures using CSF and imaging markers. But now there's plasma-based biomarkers that have come out just in the last year or so, and then they are showing increasing promise that you can predict which patients would have Alzheimer's. Now, whether they go on to develop cognitive problems or not is a whole different thing. But there is a new diagnostic criteria and new payment models coming out for patients with dementia. So the field is really in a nice space for work. And we really don't need to wait until death, as used to be the case with ultimately diagnosing Alzheimer's through autopsies. And you can see the range of biomarkers from PET scans, which are obviously very hard, and as I'm mentioning about disparities, are not really feasible in a lot of settings. CSF, which is really great, but the problem is, again, we don't have enough, primary care physicians who would really start doing LPs in their clinic, and getting an appointment with neurology continues to be a real big challenge. So, but the plasma biomarkers could shift this whole game, and which is what excites us in terms of trying to understand the disease and disease progression. But as I mentioned, that not only we are really excited about the developments taking place, but this study that we are just about to publish was also highlighted in the media about the big problem we have, that for a lot of time, primary care physicians are blamed for not screening and patients with for cognition. And the reason has been manifold. It's like the USPSTF, which is one of our guiding agencies, tends to keep it at the evidence is not enough to start screening regular patients. But now that there's treatment option, there is new ways in which we can intervene, there is definitely going to be a push that maybe screening should begin. And this is a study that I collaborated with people in Indiana, and it showed that 62% of primary care patients have unrecognized mild cognitive impairments, and 12% have unrecognized dementia. And not surprisingly, again, 82% of African Americans had undiagnosed dementia compared with 64% of whites. So thankfully, Georgia, thanks to Dr. Alan Levy's leadership, already was suspecting that new treatments are going to come out, biomarkers will change the field, started working on something called as Georgia Memory Net, which is what I was mentioning about the urban-rural differences, is really having sites all across the state where patients can really get screening done. And hopefully ones that can get on Leqembi, where you have to be amyloid positive, can get access to treatment, further trials, and maybe resources. But all said and done, the problem happens is when you start screening, how do you really, there's a lot of advantage in trying to identify this amyloid pathology earlier, but it creates huge bottlenecks in the system too. And that's what we're currently trying to solve through GMN and working with our specialists in neurology, is how do we get patients in access to these treatments and resources. So, so there's a lot of stress being paid on in reducing, getting faster diagnosis for people, showing them the value of diagnosis, I think, which is the biggest challenge, and then moving on to them in different treatment paths. And, you know, I mentioned about this whole cardiovascular health, but really you have to apply it and it was initially called Simple 7, which I always wondered, like, it's such a difficult thing to do really in primary care, is emphasize, and how do you emphasize people about the value of vascular risk factors and exercise and all that. So this is data from FINGER study, which really was a landmark study in terms of how it really showed that when patients who are high risk for Alzheimer's and dementia were given an intensive intervention, which is a package of nutrition, exercise, cognitive training, and vascular risk, compared with just regular health advice. And you can see the difference in terms of that it showed that a multi-domain intervention could improve or even maintain cognitive functioning for at-risk people than the general population. Now, this study has been like landmark in the area of AD because it shows lifestyle interventions work. And I already mentioned that to you with the 40% reduction in thing. And this is now being expanded across several countries in different formats, trying to see which kind of lifestyle intervention packages really work. And it's called the Worldwide Finger Study. The US has a counterpart called the US Pointer Study, which is going to publish its results in the next couple of years. We here in primary care also want to do something, and given how we had seen COVID pandemic and realizing that patients would not really be wanting to travel to get a lifestyle intervention. So we launched a couple of pilot studies trying to understand the value of how lifestyle interventions can change people's cognition and other vascular factors, as well as stress and mood. We call it the Lifestyle Intervention Guidance for a Healthier Tomorrow. And over the past few years, I've really learned a lot in terms of how challenging it is to do it. So we have different formats in how we intervene. We, of course, wanted to do, we in fact started with web-based intervention even before the pandemic and when Zoom was a new thing. And it took us almost like 4 to 5 sessions just to get people familiar with a Zoom intervention. And then, of course, in-person one. And we're trying to see which one works better. And interestingly, the early results show that they're comparable. Web group, I think we suffer from the challenge. There's not as much cohesion, but it also showed us in terms of the intervention involvement and what we should really intervene on. Because when we kept our intervention focused on stress, I was super excited when stress was coming out to be a factor for cardiovascular, for cognition. But the problem was if you focus too much on stress, of the cohort that started with 15 participants, only 2 were left who wanted to do the intervention any further. So ultimately, it came down that putting importance on not just one factor, but really giving a comprehensive intervention, just like what you would do in the diabetes area, like a diabetes prevention program, would similarly operate over here for our participants to keep them engaged for changing their lifestyle. So just to summarize, less than 1% of the U.S. population has ideal cardiovascular health, and this really plays a role in terms of how it would play for brain health as well. And a lot needs to be done. But some of our studies have shown that, yes, if you even do smaller changes, which has really a good buy-in when you try to talk to people about not getting to the ideal levels of 150 minutes of exercise, but just making those small changes could result in a substantial reduction in both cardiovascular and even potentially Alzheimer's disease, and also reduce disparities. And I've mentioned that the cardiovascular health is really closely tied to brain health, and in several domains, as we've seen in executive function and recall and everything else. And keeping in mind that the interventions, when you really start playing them out, if you start it too late when patients are already developing mild cognitive impairment, it may not give you the best, because the accumulation of amyloid and tau really starts 15 to 20 years. So what is the exact timing of the intervention is what we're trying to figure. Is it, how intensive should it be? Should it be 6 months? Should it be that? And what I'm always intrigued to understand is that when we have some weaker treatments that have come out now, like Leqembi, which of course is making a lot of noise because of how it really removes amyloid from the brain. But could you really combine treatments like Leqembi with a lifestyle package, and then you could really achieve much more significant reductions in cognitive decline and actually hope for cognitive improvement? So that's something which really excites me in the field, is how would combining this using these biomarkers, which are now coming into the fray for regular use. In fact, you can actually order like a plasma-based biomarker, like you can ask your physician to order it and know your AD risk. But how much it's going to be of value in regular care is still needing to be determined. And again, as I mentioned about the early and midlife is where things really need to be improved for achieving the best for your heart and brain health and everything else. Now, I always find this fascinating that we feel like we're discovering something novel here, but this has been emphasized centuries ago by Hippocrates, who said that if you could give every individual the right amount of nourishment and exercise, not too little and even not too much, we would have found the safest way to health. I found that fascinating that even at that time, he was thinking about people eating too much, which probably happened in the aristocratic society at that time, but now it's widely prevalent. So going back to the Holy Grail thing that I mentioned, so I mentioned about like how we're always looking for that one medicine, one thing that could change things. And from a patient perspective, you could, maybe if it's a once weekly dosing, even better. But this is a famous painting. I don't know if you recognize this. This is called the Fountain of Youth. And I find this fascinating because the Fountain of Youth is really meant where people, you can see on one side coming with disease, disability, poor aging, and they take a dip in this nice water, like, and then they come out refreshed, young, and healthy. That, I think as medicine also, we are trying to search for something similar. But I took it and reframe it in a different way. It's not really nothing about the water that's making a magic. It's really about people swimming and doing exercise and getting fit, which is what makes them reverse their aging and improve their heart and brain health. And finally, I'd like to conclude that I'm like a true primary care doc who works collaboratively with awesome people in the field, from cardiology to epi and in neurology and geriatrics, and really thankful to them for mentoring me. And this is a small team that I have where we pilot intervention and now study biomarkers to understand AD and vascular links. So thank you and look forward to questions.
Thank you, Ambar. That was excellent. Great talk. Open to questions, and if you want to put it in chat, I can read them out as well. But just to get us started, couple of things. You showed a lot of good epidemiological work to convince us that the cardiovascular risk factors, or AHA, 8 and so on have a relationship with cognition. But a lot of the times you were saying that, if you reduce the population score by 0.8, there's amazing improvement. Well, that is a stretch. These are all associations and correlations. Reducing it in a population by 0.8 or whatever has never been done. And I wonder whether some of this is a bit like the estrogen era, remember?
Yeah.
And many examples like that, where it was truly correlated, but had nothing to do with the estrogen itself. And how much of that we are dealing with, because there isn't a relationship, or is there, between all these risk factors and the amount of amyloid that's being deposited in brains, if that's a true pathology. And why are there not a million statin trials that have shown improvement in cognition? Because they certainly improve cardiovascular health dramatically, and the ACE inhibitors and the SGLT2s and whatever. So I was just wondering whether there are enough interventional studies to convince us that what seems to be a huge correlation everywhere you look is truly causative.
Great questions, Dr. Karimi. So let me start with the first part, the last thing of what you mentioned about the statins and how, interestingly, I'm part of we are one of the sites for the preventable study, which is the largest study in older people, and trying to look at is statins can prevent cognitive decline. And it's been controversial throughout, but they felt like you need a trial to do that. So it's enrolling 20,000 people all across the country. Extremely challenging study to implement. You can imagine if anybody is that old, why would they want to get in a study? So that question is unanswered from a statin perspective. But I do feel what I'm more reassured when there's always been like lifestyle factors playing a role. The problem is, how do we do it? And I felt like really energized when I looked at the FINGER study, which is the FINGER trial, which actually showed that when you reduce risk or do aggressive monitoring of your vascular risk factors, it does reduce your cognitive decline. And that study, and I'm happy to share that study with everyone, but I think that is an example where the smaller reductions, if you do it at a massive level, can really play out. And for that reason, I think both NIH and Alzheimer's Association are investing several millions and billions of dollars across to support these studies in different. It's called the Worldwide Finger Study. So, so I think that is one of the ways in which we can truly know if what we are seeing in observational data is really playing out. When I look at it from a primary care perspective, I think the problem happens is that it's I try to show people this data, but it's really hard to do. And, what leads people to stick to behaviors is, I think, a whole different challenge. Where whatever we might see in people with being in intensive trials where things are so programmed and people are already interested, it will never happen to that real extent, as you are right, when you start implementing in actual populations. So yes. I see a question from Paul, Dr. Raghi. How are you?
Hi, I'm good. How are you doing, Ambar? Thank you for taking the time to talk to us.
Yes.
I have an interest, particular interest, both personal and professional, in exercise rehabilitation. You mentioned that probably the exposure to risk factors or to good behaviors is more important when you're a young man than when you're an older man, if I understood you correctly. In other words,
right, especially for dementia. Yes.
Right. So is that a hope? We have all these rehab programs that we offer. And let's not talk about a rehab program offered to an 88-year-old, but say that somebody has a heart attack at age 60. Is there something to benefit from rehabilitation, physical exercise at that time, in terms of reduction in improvement, or rather maintenance of good cognition in the future?
Oh, I absolutely agree. That's why probably there are rehab programs that are really paid by insurance companies when you have a stroke or an MI. The problem is, how do you do rehab program when somebody does not have risk factors or just has beginning of risk factors? The rehab program would have to run almost like a life course to be in a rehab program that starts
makes
in
a
midlife,
difference.
and that's very hard to do. But I think the benefits, especially in terms of cognitive benefits, it's when I look at even the studies that I'm doing right now, when we have patients, even in the MCI spectrum, even when patients are on the worst end of the MCI, they're just not able to do things. It's like, they either have so many other comorbid conditions, and you have to give them a choice, of what they can really realistically improve. You ask them to run or walk 150 when they already have arthritis and stuff like that. You have to be really realistic of what they can do and really tailor it. One of the studies, so again, I feel like the later you do, the less benefit you will really accrue. But the thing is, it's never too late. I think even at that age, even if cognition is not affected that much, you could still benefit from just improvement in your mood and other things. So, which is what we consistently see in all of our clinical pilots that we are doing over here. But I think to your point, earlier life and midlife, what we showed through the twin study and other data that's coming out is really critical to show that people just have to get used to doing it early and not be in programs.
Very good. Thank
Viola.
you.
Yes,
Yes.
hi. Hi, Amber. Thank you for this excellent presentation. I really enjoyed it. A little bit of a challenging question, also building up on the previous discussions. So your presentation has, covered some of the biological potential pathways underlying Alzheimer's disease risk, and you touched on potentially the importance of screening and building models to predict dementia. But then, when you discuss the interventions like the finger study, essentially the most important part of it seems to be lifestyle intervention, right? Also because it makes sense, because as you said, vascular disease is one of the major factors underlying dementia. So given that, do we really need to screen people? Do we need to do this prediction modeling when we could just emphasize interventions across the board for everyone, given that, everyone essentially is at risk of cardiometabolic conditions?
Great question. I'll give you an answer in sense of thinking like a primary care doc right now. Is until I tell a patient that they are at high risk for something, the buy-in to do a lifestyle intervention is really poor. I think we struggle with that all the time. Sometimes just the discussion on risk puts people more at guard, or they really need to take it seriously. So I think that is one thing I feel is important. In terms of, yes, lifestyle, we have all known that is really good for everyone, good for prevention. But until I tell you, oh, you are really at a high risk, your screening shows, as I showed you, how much of undiagnosed mild cognitive impairment that people, we find it really challenging because it's not part of our guidelines to screen everyone for mild cognitive impairment. But we need to come up with better tools, because I think just when you start screening positive for something, even if it's not a definite path to dementia, you are high risk and you can get there in an accelerated way. So I think people take it more seriously. So I would just go with that. It's I really feel screening is important, and and more, now the biomarkers that are coming out, as well as the treatments that are coming out in AD, will definitely open the thing. The problem from an implementation perspective is there'll be huge bottlenecks, because we really can get all these patients who screen positive. What my dream is that we, until they qualify for one kind of clinical treatment, we have an option to give them, like a lifestyle package, like you could do with pre-diabetes patients, like a rehab program that Dr. Paulo Raji mentioned, that you can do a 6 months, so you already are in that mental shape to reduce your risk.
Thank you.
I think there's one question in the chat. Sprint Mind study. Yes, absolutely. It's again, to answer Dr. Kayumi, I think that is another trial which showed that aggressive control of risk factors, particularly blood pressure, which has always been very controversial in cognition world, because if you lower the blood pressure too much, you risk, like a poor cerebral blood flow and decline. So that is an example of a study that showed aggressive is important.
Okay. Excellent. Thank you, Ambar. Great
Thank you,
talk.
Dr. Graham. Thank you very much for inviting.
We'll have you back in a couple of years to tell us the results of all these interventional studies.
Yes.
A little bit more.
Yes, and thank you again for your, Viola, and Naum and your mentors in neurology, all the help and guidance along the way. Thank you.
You're welcome. We'll send you the bill. Thank you very much, everyone.
The preceding program is copyrighted by Emory University.